Imagine this. You've got this nagging fever, right? Kind of comes and goes like a tide. And these drenching night sweats. You wake up just soaked. Maybe there's this deep aching joint pain too, seems to move around. You go from doctor to doctor, you do all these tests, but nothing really pins it down. It's this persistent, really bewildering illness, a medical mystery almost. And this isn't just hypothetical. For people grappling with certain elusive infectious diseases, this is their frustrating reality.
Absolutely. That diagnostic odyssey, it's exhausting.
Welcome to the deep dive. This is where we take your source material, articles, research, maybe your own notes, and we really dig in. We unearth those critical insights, the surprising facts, the aha moments you need to get truly deeply informed. Our mission today: an exhaustive exploration. We're aiming for, well, a mastery-level understanding of some really fascinating, often misunderstood infections. We'll touch on the aquatic threats, the Vibrio infection, but our main focus, our real deep dive today, is into a master of biological deception: Brucellosis. And we'll also briefly, but importantly, look at another significant zoonosis, Tularemia, especially given its potential as a biological threat.
That connection is key.
So with that context, let's really start pulling back the curtain on these pathogens. We're going beyond just, what they are. We'll explore how they interact with the body, subtly, the whole diagnostic dance, and what it actually takes to treat them effectively. Get ready, because the details here, they're incredible. They really reshape how you think about infectious disease.
And what's truly fascinating, particularly with Brucella, is how these organisms don't just invade. They have these incredibly sophisticated strategies to actively evade our immune systems, even manipulate them.
Wow.
If you connect that to the bigger picture, it just underscores this constant evolutionary dance, doesn't it? Between pathogens and hosts. And it really shows why critical thinking about every single diagnostic clue, every aspect of treatment is just so essential. It's rarely a straight line from symptom to cure. Mastering this information means understanding the organism itself, its nature, its tricks, its weaknesses.
That makes perfect sense, especially thinking about how long some of these things have been around, co-evolving with us and animals. Okay, so let's start our journey in the water. Vibrio species. These are bacteria often found in saline environments, right? Salt water.
Exactly. A whole genus or group found in salty water. Many are harmless, thankfully, but a few are quite notorious. Significant health risks.
Right. And when we talk serious Vibrio, the name that comes up is Vibrio vulnificus, the wound maker, they call it.
Aptly named, unfortunately. While it is rare, which is good news, it's still the most common cause of severe Vibrio infections in the U.S., and its presence is tied to coastal waters, especially during warm summer months, think May to October. It absolutely needs that saline environment to proliferate.
So geographically, coastal states mainly?
That's where you see it, coastal states. And interestingly, demographically, the statistics show it most commonly affects men over 40.
Okay, a coastal warm weather threat often hitting a specific group, and the sources say it presents in two pretty distinct, quite serious ways. The first is primary sepsis, targeting people who are already vulnerable, particularly with liver disease.
Spot on. Patients with conditions like cirrhosis, that's severe liver scarring, or hemochromatosis, where the body stores too much iron, they're particularly vulnerable. And here's a really crucial insight. Vibrio vulnificus's virulence, its ability to cause disease, is dramatically increased when there's iron overload.
Iron acts like fuel for it.
Like superfuel, exactly. Which directly explains why it's so dangerous for patients with hemochromatosis who naturally have high iron levels. Other risk factors, things like hematopoietic disorders, blood cell formation problems, chronic kidney issues, people on immunosuppressants.
Weakening the immune system.
Right. Heavy alcohol use is also a factor, and very, very rarely, even healthy individuals can get this severe form.
That amplification by iron is really striking. So, okay, someone's exposed, it's aggressive. How fast do things happen? What does this primary sepsis actually look like?
It's incredibly fast. The median incubation is just 16 hours. So really rapid onset, you see malaise, that general unwell feeling, chills, high fever, and profound prostration. Just utterly drained. And about a third of patients will have hypotension, dangerously low blood pressure, often even before they get to the hospital. But here's the critical diagnostic clue, the thing that should set off alarm bells. The skin manifestations, these distinctive skin lesions, they show up in most cases, usually within 36 hours of symptoms starting, typically on the extremities, arms and legs, but more often the legs. And the progression is quite characteristic and frankly alarming to see. Starts as red patches, erythematous patches.
Right.
Then evolves into deep bruises, ecchymoses. Then you get vesicles, small blisters, and then bullae, which are large blisters, sometimes tissue death, necrosis, and slouging too.
Wow.
So if you see a patient with sepsis and these rapidly progressing hemorrhagic, blistery skin lesions, especially if they have liver disease, and that coastal exposure history, Vibrio vulnificus needs to be right at the top of your list.
That's a very clear and, yeah, alarming picture. What about the stuff you can't see? Lab findings. And what's the outcome usually once it takes hold?
Well, in the lab, counterintuitively, you often see leukopenia, a low white blood cell count more often than leukocytosis, a high count that's often alongside thrombocytopenia, low platelets, and high levels of fibrin split products, indicating clotting problems.
Okay.
You can usually culture the organism, grow it in the lab from the blood or from those skin lesions. But unfortunately, even with prompt treatment, the mortality rate for Vibrio vulnificus sepsis is tragically high. It approaches 50%.
50%. Wow.
Primarily due to just uncontrolled sepsis, that overwhelming systemic inflammation. It really highlights why immediate aggressive treatment is absolutely vital.
And what does that treatment involve? What's the protocol? It's clear and urgent. Immediate empirical antibiotics, meaning you give them right away based on suspicion before the culture results are even back. Aggressive surgical debridement, cleaning out any dead or dying tissue, and comprehensive supportive care for sepsis, managing blood pressure, organ function, all of that.
And the antibiotics, what works?
In vitro, in the lab dish, it's sensitive to tetracycline, fluoroquinolones, and third-gen cephalosporins. Animal model data, which often guides us initially, actually suggests that for septicemia, you'd use either a fluoroquinolone alone or a combination of tetracycline plus a third-gen cephalosporin. That combo gives broader coverage, potentially a synergistic effect.
Okay, that sounds like a really frighteningly fast infection, but you mentioned a second type, a primary wound infection. That sounds maybe a bit different, less severe.
Generally, yes, it is less severe. The primary wound infection usually affects people without that significant underlying liver disease. It can complicate a fresh cut or even an old wound if it comes into contact with seawater.
But the incubation here is even shorter, often just 4 hours up to 4 days, with an average of only 12 hours. Symptoms are localized initially. Swelling, redness, intense pain right around the wound. This quickly progresses to cellulitis, a spreading skin infection, and again you can see those vesicles, bullae, or necrotic lesions.
But it stays localized more.
Generally, yes. Unlike sepsis, metastatic events where the infection spreads far from the original wound are uncommon with these localized infections. Most patients will have a fever and leukocytosis, a high white count. Diagnosis is usually by culturing the bacteria right from the skin lesions, sometimes from the blood too. And with prompt antibiotics and debridement if needed, these cases are usually curative. You stop it before it goes systemic.
So what makes Vibrio vulnificus so potent then? What are its weapons, its virulence attributes?
Its main tools are its capsule, that protective outer layer. It helps it resist phagocytosis, being eaten by our immune cells, and resist the killing activity of our blood serum. It also has a cytolysin, a toxin that directly damages our cells. And as we stressed, that virulence gets massively amplified by iron overload. Some researchers also suggest it might cause gastroenteritis, stomach flu on its own, but really the big concerns are those rapid wound infections and the sepsis.
Got it. Now, what about Vibrio alginolyticus? That sounds like maybe a milder relative.
It is, thankfully, much milder. Z. alginolyticus was first ID'd as a human pathogen back in '73. It commonly causes eye, ear, and wound infections, often linked to beach contamination, hence the name alginolyticus, thinking about algae-rich marine spots.
Right.
While severity can vary, these infections usually aren't serious. They tend to respond well to standard antibiotics and draining any local pus. So think swimmer's ear, otitis externa, middle ear infections, otitis media, pink eye, conjunctivitis, bacteremia, bacteria in the blood is rare and mostly just happens in immunocompromised people.
And treatment.
Usually just tetracycline clears it right up. So yeah, a much less menacing character compared to V. vulnificus.
Okay, that's a good distinction. So we've gone from these immediate aggressive threats lurking in the ocean. Now we turn to a pathogen that really defines stealth. It's plagued humans and animals for centuries, earned this poetic but confusing name, undulant fever.
Ah yes, brucellosis.
Brucellosis. It's not just an infection, it's like a masterclass in biological deception. Understanding it means becoming a real medical detective. This is where it gets really interesting.
And it raises that important question, doesn't it? How can a disease with such incredibly varied symptoms, often mimicking other things, and an organism so adept at hiding, how can it still be so prevalent globally? It really challenges our diagnostics, our public health approaches, forces us to think critically about how these things work and how we unmask them.
Exactly. So let's define brucellosis. It's a bacterial zoonosis transmitted from animals to humans, directly or indirectly. Main sources: domesticated ruminants, sheep, goats, cattle, and also swine, pigs. And it got that name undulant fever because of its characteristic fever pattern. It waxes and wanes, rises and falls, undulates.
And what's absolutely critical to grasp right from the start is its exceptionally wide range of clinical manifestations. It's a true chameleon. It often lacks any single definitive sign that screams brucellosis.
So you need tests.
Always. Strong clinical suspicion almost always needs backup from bacteriologic tests, culturing the bacteria, or serologic tests looking for antibodies. You just can't look at someone and know for sure without those labs.
And the culprits are the Brucella species. Now, there's been some debate about classifying them, hasn't there?
Yes, there certainly has. Initially, based on early genetic work, some suggested it might just be one species, B. melitensis, with different variants. But that view's been refined. There are significant differences in their chromosomes and, critically, their host preferences, which animals they tend to infect.
Right.
So the traditional classification into distinct nomen species, named species, is now generally favored. And this isn't just academic. It matters because this classification reflects the real-world epidemiology, how it spreads, which is vital for control.
Okay, so let's break down these nomen species and their main animal hosts. This feels fundamental to understanding where it comes from.
Absolutely. First, B. melitensis. This one is, without a doubt, the most common cause of symptomatic human disease worldwide. Main sources: sheep, goats, and camels.
Okay.
Then B. abortus. Humans usually get this from cattle or buffalo. B. suis is generally from swine, pigs. But interestingly, it has variants found in reindeer, caribou, even some rodents.
Reindeer.
Yep. Then B. canis, as the name suggests, mostly from dogs.
Yep.
B. ovis causes reproductive problems in sheep, but importantly hasn't really been linked to human disease.
Yeah.
And B. neotomy is found in desert rodents, with only rare human cases reported.
And it's not just land animals. I saw mention of marine species, too. That feels relatively new.
It's a fascinating and increasingly important area. Two species, B. seti and B. pedialis, have been found in marine mammals, seals, dolphins, whales. We've already seen lab-acquired human cases from these.
Wow.
And several cases of natural human infection, too, likely from contact or contaminated seafood. Given how widespread Brucella seems to be in marine mammals globally, it's highly likely we'll find more human cases linked to the sea. The whole genus is expanding new strains found in frogs, bats, other rodents. It shows incredible adaptability.
That evolutionary journey from maybe soil bacteria to these stealthy invaders is profound. So where did Brucella come from evolutionarily? Where does it fit in the bacterial family tree?
What's really intriguing is its close genetic link to the genus Ochrobacterium. These are bacteria usually found in the environment, sometimes causing opportunistic infections in humans.
Okay.
Genomic studies looking at the whole genetic map are really shedding light on Brucella's evolution. It seems they likely started as free-living soil bacteria and adapted over millennia into these highly successful intracellular pathogens we see today, a real transition from environmental dweller to master invader.
Amazing. So speaking of its nature, what are the basic microbiological facts? What does Brucella look like under the microscope? How does it grow in the lab?
So what are we dealing with? They're small gram-negative bacteria, meaning they don't hold on to a specific stain in a common lab test. They don't have a capsule, that protective outer layer some bacteria have, and they don't form spores. They look like little rods or coccobacilli, kind of short, stubby rods.
Okay.
They need oxygen to grow, aerobic. They grow on peptone-based media, standard nutrient stuff, usually at 37 degrees Celsius, human body temp. Some grow better with extra CO2. But here's the key. Once inside a host, in vivo, they act as facultative intracellular parasites.
Meaning they can live inside or outside cells, but prefer the inside.
Exactly. They're versatile, but they really thrive within our cells. That intracellular lifestyle is absolutely central to their stealth strategy.
That makes sense. And how tough are they outside the host? In the environment, this must be huge for transmission.
Well, they're sensitive to some things. Direct sunlight, radiation, moderate heat, boiling, pasteurization kills them effectively. But here's where their resilience is really important. They're remarkably resistant to freezing and drying.
Drying, so they can hang around in dust.
Precisely. That resistance to drying makes them stable in aerosols, tiny airborne particles, which facilitates airborne transmission, a major concern, especially in places like farms or labs. They can survive for up to 2 months in soft cheeses, from unpasteurized goat or sheep milk hence the food risk.
Wow, 2 months.
At least 6 weeks in dry soil contaminated with animal discharges, urine, placental tissues, and even longer, 6 months or more, in damp soil or manure, especially if it's cool and dark.
So farm environments are a reservoir.
A major one. And while common disinfectants work under ideal lab conditions, they're much more resistant at low temps, or if there's lots of organic material around, like manure or blood-typical real-world farm conditions. This environmental hardiness is a big factor in why it persists.
That ability to survive outside, especially in food and potentially in the air, really explains its global reach and how it spreads. No wonder it's so widespread.
Exactly. Brucellosis is a zoonosis where its occurrence, its control, is directly tied to how common it is in domesticated animals. It's worldwide, really, except for those few countries that manage successful eradication in animals. But the true global prevalence in humans, we actually don't know.
Why not?
Mostly due to diagnostic imprecision. It gets misdiagnosed a lot, and just inadequate reporting and surveillance systems in many parts of the world, especially in areas with fewer public health resources.
So where are the hot spots now? Where are we seeing high incidence and what's driving it?
We're seeing increased recognition in places like India, Pakistan, Sri Lanka, parts of China. Importations pop up in Oceania, like Fiji, in Southeast Asia, Thailand, Vietnam, often via travel or imported goods. In Europe, there's a clear socioeconomic link. Incidence is inversely related to GDP. Poorer countries tend to have higher rates.
So it's linked to poverty and lack of resources.
Often, yes. In both developed and less resourced places, human brucellosis often correlates with rural poverty, maybe hygiene issues, lack of access to good medical care, and a huge factor driving emergence or reemergence, like we're seeing in some Eastern Mediterranean countries, is the failure of veterinary control programs, often due to conflict, political instability, or just lack of money.
And it sounds like the animal side of things is vastly underestimated, creating this hidden reservoir.
Yeah, it's the core problem.
Huh.
Even in well-resourced areas, the true incidence in animals might be 10, even 20 times higher than what's officially reported. That massive underestimation really cripples efforts to control the human disease.
Right.
If you look at control efforts by species, bovine brucellosis, B. abortus, has seen success. Eradicated in cattle in much of Northern Europe, Australia, New Zealand, Canada, reduced to low levels in the U.S. and Western Europe through strict test and slaughter programs.
But the story's different for B. melitensis, the sheep and goat one.
Unfortunately, yes. Eradicating B. melitensis from sheep and goats have been much less successful globally. These programs rely heavily on animal vaccination, but funding and political will fluctuate, so application is inconsistent.
Leading to ongoing problems.
Big problems. B. melitensis remains a major public health issue in Mediterranean countries, Western Central Southern Asia, parts of Africa, South Central America. You can even spill over and cause serious outbreaks in cattle, like we saw in Israel. B. abortus is still common in cattle areas in Africa, like Kenya, Uganda, and B. canis in dogs. Present on most continents, actually increasing in North America and parts of Europe, often linked to importing dogs from endemic areas. Global trade plays a role.
So, given this huge animal reservoir and the bug's hardiness, how do humans typically get it? What are the main exposure routes for us?
Usually it's through direct occupational or domestic exposure to infected animals or their products. So farmers, shepherds, goat herds, vets, slaughterhouse workers, meat processors in endemic areas, they're at high risk.
Makes sense.
And critically, lab workers handling Brucella cultures or infected samples are also at significant risk. That's why strict containment, biosafety level 3 usually, is absolutely essential in labs dealing with this.
Very important safety point.
For travelers or city dwellers without direct animal contact, it's usually through contaminated food. And in countries that have eradicated it in animals, new human cases are mostly acquired abroad. A reminder of that global connection.
Food seems like a major vehicle then. What kinds of food are we talking about? Any unusual sources?
Dairy products.
Yeah.
By far the most common source globally, especially soft cheeses made from unpasteurized milk. Unpasteurized milk itself, even ice cream made with it. The key is unpasteurized.
Right, pasteurization kills it.
Exactly. Raw meat, bone marrow can be sources occasionally, but much less common than dairy. And interestingly, there have even been reports of infections linked to cosmetic treatments using materials of fetal origin. Definitely an unusual route.
Wow. Okay, we've covered general transmission. What about person-to-person spread? And you mentioned bioweapons potential. What's the risk there?
Person-to-person transmission is extremely rare, almost negligible. So casual contact isn't a worry. Transfer via blood or tissue donation is also incredibly rare. But a really important safety point. Accidental injection or swallowing of the live animal vaccine strains, B. abortus S19 and RB51, B. melitensis rev1, can cause disease in humans. Those vaccines need careful handling.
Good to know.
And yes, the bioweapons angle is sobering. B. melitensis and B. suis were historically developed as bioweapons. Public health officials and doctors should keep that possibility in mind if there's a sudden, unexplained outbreak of fever, especially in a non-endemic area. A deliberate release is, unfortunately, conceivable.
Truly sobering. Now, before we get into how it actually makes us sick, is there any group that's particularly vulnerable, like immunocompromised people, which we often worry about with infections?
It's a reasonable question, especially for a chronic intracellular bug. But surprisingly, despite Brucella being exactly that, there isn't strong evidence for increased prevalence or severity in people with HIV or other forms of immunodeficiency.
Really? That's quite unexpected.
It is. It distinguishes it from many other chronic infections that really hit immunocompromised people hard. A crucial point.
Definitely valuable info. Okay, let's pivot to the host-pathogen interaction. How does our immune system react to Brucella, and what are Brucella's specific strategies to get in and stay in? This is the core of its stealth pathogen identity, right?
This is absolutely the core of understanding its success and persistence. When we're exposed, our body mounts both humoral, antibody-based, and cell-mediated immune responses. We try to fight back. But here's the problem. Antibodies are great at clearing extracellular brucelli, the ones floating around outside cells.
Yeah.
They can directly kill them or tag them for phagocytosis, for immune cells to eat. But antibodies alone cannot eradicate the infection.
Why not? Because they're inside the cells.
Precisely. These organisms are masters of intracellular survival. They set up shop, establish persistent infections right inside our own cells, especially macrophages, where antibodies just can't reach them.
So the macrophage, our immune system's cleanup crew, becomes their hideout. What tricks do they use to survive inside the very cells designed to kill them?
This is where their stealth really shines. They have several incredibly sophisticated ways to turn our defenses against us or just bypass them. First, they actively suppress the intracellular killing pathways within the macrophage, and they inhibit apoptosis-programmed cell death of the infected cells.
So they disarm the cell and stop it from self-destructing to contain the infection.
Exactly. Imagine a burglar disabling the alarm and convincing the homeowner not to call 911. This allows the bacteria to build up huge populations inside the cell without being eliminated or even detected effectively. Plus, they masterfully evade destruction by preventing their little compartments, the Brucella-containing vacuoles they create using their type 5e secretion system from fusing with lysosomes.
Lysosomes. Those are the cell's acid baths, the disposal units.
Right, the recycling center is filled with enzymes to break down invaders. By stopping that fusion, Brucella avoids being digested. It essentially stays safe in its own private, non-acidic bubble inside the macrophage.
That's incredibly clever, like having a cloaking device and a shield inside our own cells.
It really is. And another crucial stealth move. They mess with dendritic cells. They prevent them from maturing properly, inhibit their ability to present antigens, those wanted posters for the immune system, and stop them from activating naive T cells, the soldiers that need to be called into action.
So they stop the alarm from sounding properly.
Essentially, yes. By interfering with this critical step, they prevent a strong, targeted immune response from getting properly mounted. They hide, replicate, and spread largely under the radar of key parts of our adaptive immunity, letting the infection persist.
Truly remarkable evasion. What about getting into the cells in the first place? Is it always direct invasion?
Well, if bacteria are opsonized, tagged by antibodies or complement proteins,
Marked for destruction.
exactly, they get actively engulfed, phagocytosed, by neutrophils and monocytes. That attachment happens via specific receptors, Fc for antibodies, C3 for complements, etc. And these opsonized bacteria do trigger an oxidative burst inside the phagocyte, that chemical explosion trying to kill them.
Okay.
But unopsonized bacteria, those without the tags, get internalized much less efficiently. And interestingly, the smooth strains of Brucella seem to prefer entering host cells via lipid rafts, these specialized patches on the cell membrane.
And their outer layer, the LPS, the lipopolysaccharide, and that plays a unique role too, doesn't it? It's different from other gram-negative bacteria.
A critical point. Brucella's smooth LPS is unusual. It has a distinct structure and, crucially, relatively low endotoxin activity. Endotoxin normally triggers a massive inflammatory response, septic shock sometimes.
Right.
Brucella's low-activity LPS likely contributes to its ability to cause fever, paragenicity, without it being overwhelming, and helps it resist phagocytosis and serum killing in someone not already immune. Plus, the LPS itself is thought to help suppress that phagosome-lysosome fusion we talked about.
So it actively helps them hide.
Yes, and it's thought to help divert the internalized bacteria into special vacuoles in the endoplasmic reticulum, which becomes their preferred spot for intracellular replication.
Yeah.
They're not just avoiding destruction, they're hijacking cellular machinery.
It's a whole suite of survival tactics. Any other mechanisms in their arsenal against our defenses?
They have a type 5e secretion system, B. It's like a molecular syringe injecting bacterial proteins into the host cell to manipulate it. This system is key for their intracellular survival and movement within the cell. Interestingly, it can be activated differently outside the cell in B. abortus, but by low pH inside the cell in B. sus, a neat adaptation. There might be a type 3 system too, but that's less certain. They also produce acid-stable proteins to survive in acidic compartments, proteins like Qzen superoxide dismutase to resist reactive oxygen species, those toxic chemicals our immune cells use.
Like a shield.
Exactly. And maybe even a hemolysin-like protein to help them get released from infected cells in a controlled way, letting them spread without causing too much immediate damage that would alert the immune system.
So even with all these incredible evasion tricks, our immune system still tries to fight back. What are the key cytokine signals involved, and how does Brucella counter them?
It's a constant battle. Early on, TNF-alpha is produced. That's a key cytokine stimulating other immune cells and activating macrophages to kill intracellular Brucellae using reactive oxygen and nitrogen. But virulent Brucella can actively suppress this TNF-alpha response.
Wow, it fights back against the signals.
It does. So then control relies more on other pathways, especially IFN-gamma, interferon gamma. Cytokines like IL-12 promote IFN-gamma, which drives Th1 responses to the cellular immunity arm and stimulates macrophage activation. But other cytokines like IL-4, IL-6, IL-10 actually downregulate this protective response, making it easier for Brucella to persist. It's a real tug-of-war at the molecular level.
So after all this stealthy replication and immune evasion inside cells, how does it actually spread through the body and cause those widespread symptoms we talked about?
The thinking is, initial replication happens in the lymph nodes, draining the entry point wherever it got in. From there, it spreads through the bloodstream, hematogenous spread. This can lead to chronic, localized infections almost anywhere.
But it has preferred spots.
It does seem to target certain tissues more often. The reticuloendothelial system, spleen, liver, bone marrow, musculoskeletal tissues, joints, bones, causing that arthritis pain, and the genitourinary system. The tissue response involves inflammation, both acute and chronic. You can get granulomas, those collections of immune cells trying to wall it off, sometimes with necrosis or caseation, that cheese-like appearance. And abscesses can form, especially with BCs, the pig strain.
All these complex interactions lead to that really diverse set of clinical symptoms, which is why diagnosis is so tough. What's the one core symptom nearly everyone gets, and what else helps distinguish brucellosis?
The core symptom almost always is fever, often with those profuse, drenching night sweats. In places where it's common, telling it apart from other fevers, typhoid, malaria, flu is really hard early on because symptoms are non-specific. But two features, recognized way back in the 19th century, help. First, untreated. The fever has that undulating pattern up, down, up again, lasting weeks. There may be a fever-free period, then relapse. That gave it the name undulant fever.
Right.
Second, the fever is strongly linked with musculoskeletal symptoms, bone, joint, muscle aches and pains in about half of patients. That joint or back pain with a fever is a big clue.
That undulant pattern is distinctive. Do the different Brucella species cause different types of illness, or is it all roughly the same?
They do have tendencies. B. melitensis, from sheep and goats, often presents more acutely, more aggressively, sometimes more severely. B. sus, from pigs, is known for causing focal abscesses, maybe in the liver or spleen. B. abortus infections often have a more insidious, gradual onset, and are maybe more likely to become chronic, linger longer. B. canis, from dogs, is generally seen as less severe, but like the others, it can still cause serious problems like endocarditis, that heart infection. And the incubation period varies wildly, a week to several months. Onset can be abrupt or slow and gradual.
What about those general, non-specific symptoms that make it so hard to pin down early?
Things like growing apathy, lack of interest, profound fatigue, loss of appetite, weight loss, general muscle aches, myalgia, headache, chills. But to simplify it clinically, presentations often fit one of three common patterns.
Okay.
1. A generalized feverish illness, maybe looks a bit like typhoid, but usually less severe. 2. Fever plus acute monoarthritis, one inflamed joint, often hip or knee, maybe in a young child. 3. Long-lasting fever, general misery, and low back or hip pain, more often seen in an older man. In really endemic areas like parts of the Middle East, if someone comes in with unexplained fever, they're having trouble walking, brucellosis is high on the suspicion list until proven otherwise. It's the great mimicker.
So beyond those patterns, what specific things in a patient's history should make a doctor strongly suspect brucellosis?
History is absolutely crucial, like detective work. Key clues: recent travel to an endemic area, current or past job in a diagnostic microbiology lab, consuming unpasteurized dairy, especially soft cheeses, that's huge.
Right.
Any contact with animals, accidental jab with a veterinary Brucella vaccine, and, in endemic places, a family history of similar illness that pops up in nearly half the cases, showing household exposure.
You mentioned musculoskeletal issues in about half the patients. What are the specific focal signs beyond just general pain?
Focal features, localized signs, are actually present in the majority of patients. Musculoskeletal is most common, around 40%. Pain and physical findings in limbs, spine. Osteomyelitis, bone infection, tends to hit the lumbar and low thoracic vertebrae more than the neck or upper back. Individual joints, sacroiliac, hip, knee, shoulder, sternoclavicular, can get inflamed, as monoarthritis, one joint, or polyarthritis, multiple joints. This bone infection can also go along with septic arthritis, infection in the joint. And here's a critical point for mastery. Differentiating this from tuberculosis, it's vital. Why? Because some drugs treat both, and misdiagnosis is dangerous. Brucella arthritis often progresses slowly, less dramatic joint destruction than other bacteria. Starts maybe with small erosions near the joint capsule.
Subtle changes.
Very subtle. In the vertebrae, you might see faint erosions on the top surface of the bone initially, gradually involving the whole vertebra, maybe sclerosis or hardening. Bony outgrowths, osteophytes might develop later. But significant bone destruction or spinal cord pinching, that's rare in brucellosis and points more towards TB. TB often causes more destruction, more spinal cord issues, needs totally different treatment.
That comparison to TB is really crucial for getting the diagnosis right. What other body systems get involved, echoing that sort of typhoid-like picture?
Beyond the bones and joints, about a quarter of patients get a dry cough. Often the chest x-ray looks surprisingly normal, making it hard to connect to brucellosis. But more severe things can happen. Pneumonia, empyema, pus in the chest cavity, swollen chest lymph nodes, even lung abscesses.
Can you culture it from the lungs?
Rarely positive from sputum or pleural fluid, again showing how it hides. But these respiratory issues usually respond to the standard brucellosis treatment. Another quarter of patients might have hepatosplenomegaly, enlarged liver and spleen, and 10–20% have enlarged lymph nodes elsewhere. The differential diagnosis here includes things like mono, Epstein-Barr, toxoplasmosis, CMV, HIV, even TB again.
And the genitourinary system. Any specific signs there, especially for men or pregnant women?
In men, up to 10% might get acute epididymorchitis inflammation of the testes and epididymis. You have to carefully rule out mumps or surgical emergencies like testicular torsion because the treatments differ hugely. Other possibilities: prostatitis, prostate inflammation, seminal vesiculitis, salpingitis, fallopian tubes in women, pyelonephritis, kidney infection. In pregnant women, there's an increased risk of fetal loss, though less dramatic than in farm animals. But, importantly, teratogenicity causing birth defects has not been described in human cases. That's reassuring if the pregnancy continues. Neurologic involvement is actually pretty common, but often subtle initially, maybe just depression, lethargy. The severity might only become clear after treatment starts and the patient feels better. A smaller group gets more serious stuff: lymphocytic meningoencephalitis, brain inflammation.
Mimicking other serious conditions.
Exactly. It can look like neurotuberculosis, atypical leptospirosis, even non-infectious conditions. Complications can include brain abscesses, cranial nerve problems affecting vision or facial movement, even ruptured mycotic aneurysms weakened brain blood vessels.
And endocarditis, though rare, sounds particularly dangerous.
It absolutely is. Infection of the heart's inner lining may be 1% of cases, but life-threatening. Often affects the aortic valve, natural or prosthetic. And really, Brucella can cause metastatic accesses, pockets of pus, spread from elsewhere or inflammation almost anywhere. The female breast and thyroid glands seem particularly susceptible.
Interesting.
Lastly, while it causes so many issues, specific skin signs like rashes are actually uncommon and often go unnoticed by the patient. Another reason it's so visually tried to diagnose.
So given this incredibly wide, non-distinctive picture, this true chameleon, how do we actually pin down the diagnosis? What are the complexities for that medical detective?
That's the crux, and
Yeah.
where that mastery-level understanding really comes in. Because the clinical picture isn't distinctive, laboratory confirmation is absolutely essential. Standard blood tests, routine biochemistries, usually normal, maybe slightly elevated liver enzymes or bilirubin. White blood cell counts are often normal or low, maybe with relative lymphocytosis, more lymphocytes. Mild anemia is possible. In severe cases, you might see low platelets, thrombocytopenia, or even DIC, that serious clotting disorder, with markers like fibrinogen degradation products being high. Even standard inflammation markers like ESR and CRP are variable, often normal, sometimes raised, so not very helpful specifically.
What about analyzing fluids like CSF from a spinal tap or joint fluid? Do they give clearer answers?
In CSF or joint fluid, you typically see lymphocytosis, more lymphocytes, and low glucose. That indicates inflammation. But interestingly, an enzyme called adenosine deaminase can be high in the CSF in both brucellosis and tubercular meningitis. So that test doesn't help distinguish them. Another diagnostic hurdle. And if you biopsy tissue, like a lymph node or liver, you might see non-caseating granulomas, those immune cell clusters trying to contain it. But crucially, you won't see the acid-fast bacilli characteristic of TB, which helps differentiate. X-rays of bones. Changes develop late and are subtle, less destructive than TB or other septic arthritis. Isotope scans are more sensitive for early detection, but stay positive even after cure, so they're not great for monitoring treatment success.
So with all these ambiguities, what's the definitive test, the gold standard for confirmation?
Isolation. Growing Brucella in a lab culture from blood, CSF, bone marrow, joint fluid, or a tissue sample. That's the definitive gold standard.
Right.
But success rates are usually only 50–70%, so it's not always easy.
Right.
Blood cultures using modern automated systems like BACTEC usually turn positive within about 7 days. But here's that crucial safety point again. Clinicians must alert the lab if they suspect brucellosis. Cultures need biosafety level 3 containment because it's dangerous for lab staff.
Absolutely critical. And with lab automation now, is there a risk of the machines misidentifying it, making the detective work even harder?
Absolutely, a significant pitfall. Standard biochemical test strips used in many labs might misidentify Brucella as something else, like Agrobacterium or Ochrobacterium. And newer technology, MALDI-TOF-MS, which analyzes protein fingerprints. It's powerful, but the classical Brucella species are so genetically similar it can struggle to tell them apart accurately at the species level.
So even high-tech methods aren't foolproof.
Not always. The source authors mention cases of misidentification, even with MALDI-TOF, so you need caution, expert review, maybe extra confirmation tests.
Okay, so culture is gold standard, but not always positive or easy, and ID can be tricky. What about molecular methods, like PCR, detecting bacterial DNA?
PCR has enormous potential. It could be great for detecting bacteria in the blood, predicting relapse, maybe even ruling out that controversial chronic brucellosis. It's generally more sensitive and quicker than blood culture, and there's no biohazard risk handling the sample for PCR itself.
Sounds promising. Is it widely used?
It is widely used, but there's no single standardized procedure yet. Different labs use different primers targeting various genetic regions, the spacer region, outer membrane protein genes, IS711, BCSP31 protein. It works on blood and other tissues. The main controversy now is what it means if PCR stays positive for a long time after treatment. Does that indicate ongoing infection or just leftover DNA? We're still figuring that out.
So if culture can be tough and PCR has interpretation issues, what about serology? Detecting antibodies, is that more straightforward?
Serology looking for antibodies in blood is often the only positive finding, especially later in the disease or if cultures are negative. In acute infection, IgM antibodies appear early, then IgG and IgA come later. All of these work in agglutination tests where antibodies make bacteria clump together. Most patients have detectable agglutinins early on. As things progress, IgM tends to decline. The binding strength, avidity, and types of IgG change, which can actually make standard agglutination titers drop or disappear, even if infection persists. But these antibodies might still be detectable by other more sensitive tests like complement fixation, Coombs test, or ELISA assays. Interpreting the titer, the level of antibody, there's no single magic number. You have to consider the patient's history, symptoms, and where they live. In endemic areas or high-risk jobs, maybe a titer of 1.320 or 1.64 is significant. In non-endemic areas, maybe 1.160 is enough.
Context matters.
Hugely. And getting paired sera testing blood samples taken 2 to 4 weeks apart is really helpful. A fourfold rise in titer, or going from negative to positive seroconversion, is highly diagnostic of a recent infection.
So the standard agglutination test is still a workhorse despite the complexities.
It is. It's still the mainstay globally. In endemic areas, over 90% of patients with acute bacteremia will have a titer of at least 1.320 when they first present, so it's a very useful initial test. There are other tests, like the Rose-Bengal screening test, but it's only partially validated for humans. IgM dipstick assays exist but aren't widely used. Point-of-care tests are still mostly in development.
And cross-reactions with other bacteria, that must muddy the waters for serology, right? Potential false positives.
A major diagnostic pitfall, definitely. Conventional tests detect antibodies against the Brucella LPSO chain. And since B. abortus, B. melitensis, and B. sus cross-react heavily.
Testing for one picks up the others.
Right, no need for multiple tests there. But critically, cross-reactions do happen with the O chains of other gram-negative bacteria. Things like Yersinia enterocolitica 0.9, E. coli 0157, Francisella tularensis, which we'll get to, some Salmonella, Stenotrophomonas, even Vibrio cholerae.
Wow, quite a list.
It is. So a positive serology doesn't automatically seal the deal for brucellosis. You need that clinical context patient history to rule out these cross-reactors. Also, another important nuance. These smooth LPS antigens don't cross-react with the rough Brucella strains like B. canis or B. ovis. So if you suspect infection with those, you need specific tests using antigens from those rough strains, otherwise you'll get a false negative.
Okay.
And similarly, the live animal vaccine strain RB51. It doesn't trigger antibodies detectable by standard SCRUP antigen tests. That's vital if you're tracking an accidental exposure to that specific vaccine. You need specialized testing.
That is a lot of diagnostic nuance. Definitely requires expertise, being a real detective. So, okay, you've navigated this complex path. You've finally confirmed brucellosis. What are the strategic treatment approaches? How do you fight this stealthy intracellular bug?
The main goals are twofold. Treat the current infection, relieve those often debilitating symptoms, and critically prevent relapse. Relapse is common if treatment isn't thorough. For focal disease like an abscess or bone infection, you might need specific interventions, maybe surgery, plus longer tailored antibiotic therapy. And here's that critical point again, showing the real-world complexity. You must rule out tuberculosis before starting brucellosis treatment.
Because of the overlapping drugs.
Exactly. Both diseases can look similar, and some key drugs work for both. If you treat presumed brucellosis with something like rifampin alone, but it's actually TB, you'll breed drug resistance very quickly. So if TB can't be ruled out, you either avoid drugs active against TB if used alone, or you just treat for both with a full anti-TB regimen. A very serious consideration.
Definitely. So it's not just killing Brucella, but being mindful of lookalikes. What's the history of treatment taught us? What works against this tricky bug?
Well, early on, streptomycin alone led to frequent relapses, like 30–40%, unacceptable. That led to combining it with tetracyclines, which became the standard, and is still highly effective.
Yeah.
But there's that fascinating challenge. Many drugs look good in vitro, kill Brucella in a dish, but fail in vivo in the patient.
Like beta-lactams.
Assorted beta-lactams, yeah. And fluoroquinolones are still controversial. They look good in vitro, penetrate white cells well, but likely perform poorly in that acidic environment Brucella creates inside cells. It shows you can't just trust the petri dish. You need to understand the bug's intracellular niche.
So what is the standard course? The gold standard for acute non-focal brucellosis. How long does it take?
For adults with acute uncomplicated brucellosis lasting less than a month, you generally need a 6-week course with at least 2 antibiotics. For more complex or focal disease, treatment might need 3 months or even longer.
And sticking to the plan is crucial.
Absolutely vital. Poor adherence underlies almost all apparent treatment failures. True drug resistance is rare, though some TMP-SMX resistance has been reported in one place. Interestingly, for kids, retrospective data suggest 3 weeks of 2 drugs might be enough for uncomplicated cases. But we need better prospective studies to confirm that.
And the actual gold standard regimen for adults, what is it?
The gold standard, backed by decades of experience, is intramuscular streptomycin, 0.75 to 1 gram daily for 14 to 21 days, combined with oral doxycycline, 100 milligrams twice daily for 6 weeks. Relapse rates with this are pretty low, 5–10%. Excellent for this kind of infection.
Okay. What's the main alternative, the one often recommended by WHO, especially if streptomycin isn't practical?
The usual alternative and the WHO recommendation is rifampin 600 to 900 milligrams daily plus doxycycline 100 milligrams twice daily, again for 6 weeks. The relapse rate here is a bit higher, though, maybe 10–20%.
Why higher?
Possibly because rifampin induces liver enzymes that can actually lower doxycycline levels, making it less effective when they're given together. For patients who can't take tetracyclines, like young kids or pregnant women, high-dose TMP-SMX is an option. For adults, maybe 2 or 3 standard tablets twice daily, depending on weight.
Are other aminoglycosides like gentamicin an option instead of streptomycin?
Yes, there's growing evidence for gentamicin 5 to 6 milligrams a day for at least 2 weeks as an effective alternative. But, crucially, shorter courses of aminoglycosides are linked to high failure rates in adults, so you need that full 2 weeks at least. For kids with uncomplicated disease, maybe 5–7 days of gentamicin plus 3 weeks of TMP-SMX could work, but again, needs prospective trials.
And the fluoroquinolones. Still controversial. Has that debate moved forward?
Well, early trials with fluoroquinolones alone were disappointing high relapse. Using them with rifampin for 6 weeks was suggested as an alternative, but a big meta-analysis didn't support them as first-line treatment. The Ioannina expert group actually advises against routine use outside of clinical trials. However, a more recent meta-analysis was a bit more supportive. So the jury's still somewhat out. We really need a large, well-designed prospective study to figure out their definitive role in combination therapy.
So mostly dual therapy. Is there a clear role for triple drug regimens in some cases?
Absolutely. A triple regimen, usually doxycycline, rifampin, plus an initial course of an aminoglycoside like streptomycin or gentamicin, actually came out superior in a meta-analysis. Better cure rates, lower relapse.
So when would you use that?
Definitely consider it for anyone with complicated disease, endocarditis, osteomyelitis, or if you're worried about the patient sticking to the treatment plan. It offers a bit more firepower, a greater margin of safety.
And for those really severe focal forms like the neurologic disease or endocarditis you mentioned, does treatment change dramatically?
Yes, significantly. For focal neurologic disease, you need prolonged treatment, maybe 3–6 months, usually adding ceftriaxone to the standard oral drugs. Brucellosis endocarditis is super serious, treated with at least 3 drugs, aminoglycoside, tetracycline, rifampin. Many experts add ceftriaxone or a fluoroquinolone too, hoping to avoid valve replacement surgery.
How long for endocarditis treatment?
At least 4 to 6 months, and it's hard to know exactly when to stop. Long follow-up is essential. And surgery is still needed for most infections on prosthetic heart valves or joints. Antibiotics alone often can't clear it from foreign material.
What about preventing infection after exposure, say a lab accident or accidental injection with that live animal vaccine? Is there a standard protocol?
It's a critical question, but surprisingly, there's no strong clinical trial evidence to guide us definitively for post-exposure prophylaxis, PEP, but based on expert opinion and extrapolation.
Okay.
For low-risk exposure, like an unspecified lab accident, maybe rifampin plus doxycycline for 3 weeks. For major exposure, like a big aerosol release or injection, recommended is rifampin plus doxycycline for 6 weeks. These combos can have side effects, though, so doxycycline alone for the same duration might be substituted, especially for lower risk. Doxy monotherapy is actually standard PP in the UK, though not the US yet.
And if it's that specific vaccine strain, RB51?
Right, RB51 is resistant to rifampin. So you'd omit rifampin and use something else like TMP-SMX combined with doxycycline. And critically, any pregnant woman with significant exposure needs expert consultation to weigh the risks and benefits of PP.
That's a really comprehensive look at treatment and PP. Finally, let's talk prognosis, follow-up after treatment, and the bigger picture of prevention.
Relapse is a real concern. It happens in up to 30% of patients who don't take their meds properly. Underscores how vital adherence is. So ideally, you follow patients clinically for up to 2 years to catch any relapse. The good news is relapse usually responds well to another longer course of the original therapy.
How do you monitor for relapse? Are antibody levels helpful?
Actually, the patient's overall well-being and body weight are often better guides than serology. Why? Because IgG antibody levels from the standard agglutination test can stay high in the diagnostic range for over 2 years, even after a cure. Complement fixation titers tend to fall back to normal within a year, so they might be a bit more useful for tracking cure.
And immunity. If you get it once, are you protected?
Unfortunately, no. Immunity isn't solid. You can get reinfected after repeated exposures. A risk for people in endemic areas or certain jobs. Mortality rate is low, though. Fewer than 1% die. Fatal cases are usually due to the cardiac involvement, endocarditis, or rarely severe neurologic disease.
But recovery can be tough.
Very tough. Recovery is often slow, protracted, It can cause prolonged debility, significant depression, really impacting quality of life for months, sometimes years.
And this idea of chronic brucellosis, it sounds controversial. What's the deal there?
It is complex and often debated. When patients present with persistent, vague symptoms like fatigue, aches, sweats long after initial treatment, often in cases of work-related exposure, you have to be really careful. You need to exclude other things, malingering, nonspecific chronic fatigue syndromes, other causes of sweating like alcohol or obesity.
Because the symptoms are so nonspecific.
Exactly. It's tough. Maybe the future more sensitive test for Brucella antigen or DNA will help us definitively identify true ongoing infection versus other issues. That would clear up a lot of ambiguity.
So how do we prevent this pervasive disease on a big scale, especially with that huge animal reservoir? Are there human vaccines?
Prevention mostly focuses on the animals. Human vaccines using live attenuated strains exist, used in some high-risk groups in some countries, but efficacy is limited, short-term, and they can cause significant side effects. Subunit vaccines are still uncertain. Biodefense interests might drive research, but we don't have a broadly effective human vaccine yet. So the mainstay is veterinary prevention. National programs for testing and slaughtering infected herds, compensating owners, controlling animal movement, and actively vaccinating animals. When these are done well, they usually control human disease too, by tackling the source.
And for the general public?
Pasteurization. Pasteurizing all milk products before consumption is sufficient to prevent that major route of non-occupational transmission. And crucially, reporting. All cases in animals and humans must be reported to public health authorities for effective surveillance and control.
Okay. Finally, let's briefly touch on another zoonosis, one that shares some worrying features with brucellosis, especially that biothreat potential, tularemia.
And this really highlights that dual nature of understanding these bugs as natural diseases and as potential weapons, underscores why vigilance and comprehensive knowledge are so critical, covering both natural and potential deliberate threats.
So define tularemia for us. What makes it such a concern?
Tularemia is another zoonosis, animal to human, caused by the gram-negative facultative intracellular bacterium Francisella tularensis. It was first found in sick rodents in Tulare County, California, back in 1911, hence the name, and then in humans a few years later. It's a concern because it's highly infectious, takes very few organisms to cause disease, and can be severe.
Are there different types that affect humans?
Yes. Francisella tularensis is split into subspecies. Two main ones cause human tularemia. Subspecies tularensis, causing type A tularemia, and subspecies holarctica, causing type B. Both type A and type B are highly virulent human pathogens.
And they're considered a major biothreat.
Yes. Both are Category A, potential biological threat agents, according to the US CDC. That's the highest risk category agents easily spread, causing high mortality, potential for panic, and social disruption. There's also subspecies Media asiatica, and the whole Francisella genus includes several species now.
So wrapping this all up, what does this mean? We've journeyed through the immediate dangers of Vibrio, then really plunged deep into brucellosis, a true masterclass in stealth, varied symptoms, complex diagnosis, and treatment. And we touched on tularemia's significance too.
You now have a level of understanding that goes way beyond just headlines. You're equipped with detailed knowledge of how these organisms survive, how they make us sick, how we fight them. And it's not just memorizing facts, is it? It's seeing the connections to animal health, human health, food systems, even global stability, especially when you think about potential misuse.
Absolutely. The depth really changes your perspective, makes you think about biosecurity, the interconnectedness of life. And that brings us to our final thought for you to mull over. Consider this. Given the incredible adaptability of these stealth pathogens like Brucella and Francisella, their ability to jump between animals and humans, what unidentified or emerging diseases might be out there right now, circulating silently, perfecting their own strategies in the shadows? And how prepared are we, really, as a global community to spot them and confront them before they become the next big public health challenge?